So the Titan 2 data, or the Titan 2 study, represents an extension of the Titan 1 study, which was essentially a feasibility and a safety study looking at an implantable tibial nerve modulator device. So Titan 2 is looking at a group of patients with urinary urgency incontinence and implanting a novel device at the level of the ankle to improve urinary symptoms. The data we're presenting today really is an extension of the data previously presented, now looking at the 24-month outcomes. And this data, it looks at the primary outcomes and the secondary outcomes that were measured, including quality of life data, urinary urgency incontinence reduction, and safety data. So if we look at this data, it's really exciting because it really shows a continuation of both efficacy and ongoing safety in the device. What we found was essentially that the results presented earlier in the 12-month data are sustained. We didn't see any drop-off in efficacy. And also importantly, we saw no increase in adverse outcomes or any type of increased significant adverse events. As it relates to safety, there's a lot of questions about working in this area of the body. Urologists often don't work at the level of the ankle. And with this device, we wanted to really ensure that we could place it there and that it wouldn't lead to issues such as wound complication, orthopedic issues, infection, etc. And it was really found that the adverse outcomes that were seen in that area were minimal, and that only one device required explantation. So that tells us that over a 2-year period of time that it is a safe and therapy that can be offered to patients without concerns that there's going to be major adverse concerns. As a clinician, what options to offer patients? This really sheds light to the ongoing safety of working on a neural target that we hadn't before. And what it does is it just opens up an opportunity for a whole set of treatments and an opportunity to help a group of patients that might have had problems either tolerating or being eligible, actually, frankly, for a sacral neuromodulation device. So I think that this really speaks to an opportunity that's now been shown for over 2 years to be continually safe. Today was the extension data from 12 to 24 months. And I think a couple of real key points came out of that data. The first is that the results that we're seeing at 12 months remain sustained. So when we look at degree of improvement, we look at complete continence, and we look at a marked reduction of greater than 50% improvement or 75% improvement, that stayed sustained. So I think one concern has been, is this a transient therapy? Is it a therapy that may see a result for a period of time and then not be ongoing? And this data is really reassuring to show that those patients that were improved and improved over time maintain that improvement, not only in their ability to reduce or eliminate urgent incontinent accidents, but also to improve their quality of life metrics, i.e. being able to make it to the bathroom and reducing the total number of voids, and to improve their ability to handle their bladder symptoms. Major change in working in this area is because it is in the ankle and not in the back or elsewhere, it's an area that's intimidating. And I think when we look at the minimal invasive nature of this device, one thing that really shines is the ability to do under a local anesthetic. So as opposed to the other therapies we offer that may require more of a regional or a general anesthetic, this is something that can be safely done completely under local. Not only is that reassuring for us as providers, but more importantly for patients. I think patients who can become aware of their procedure, be involved, and have an awareness of what's going on, it leads to a sense of security and comfort. And that is really, from our perspective, a big thing. The second perspective of safety is the fact that this device lies above the fascia. So in the ankle, there's a determination of a fascial layer that determines where these devices are placed, either above or below the fascia. And by not having to penetrate or incise the fascia, the degree of safety is increased. So that is also really, I think, speaks to the minimal invasive nature of this, the reproducibility of the procedure, and the fact that we as clinicians can know that we can work in this space safely. So these quality of life data, I think, really reflect real world data in the fact that patients can carry on their day and have the time to make it to the bathroom, have the ability to stop an event, get to the bathroom, utilize the bathroom in a manner that it's discreet and safe for them. I think that not only is the total number of voids decreased, but the ability to get there and not have an urgent incontinent accident. The two go together. So it'd be an example of where they may be in the middle of an activity, have time to excuse themselves, make it to the bathroom. Also, just the total number of voids, meaning that, again, if we can reduce that to 2 to 4 times per day, if those were occurring at times while they were at work, while they were at school, while they were enjoying an activity, that would free them up to do those things and not to negatively impact their quality of life. I think one other thing I want to include in this dialogue is the patient selection for this study. Because as we look at these different devices that are coming on the market, there's a lot of opportunity to help patients with different forms of care and different devices. And we just really need to make sure we're comparing apples to apples. And that is the Titan study really utilized the most stringent criteria for enrollment. These were patients who were failures, essentially, who had used 2 medications, who had had a duration of the problem that was extended, and for patients that even in many cases had already done a different advanced therapy that could be something such as onabotulinum toxin or sacral neuromodulation. So these patients really reflect the real world. You might say they're not cherry-picked. They're not patients who may have a lower threshold to response. And I think as we as clinicians look to the patients we treat, many of these people with these other issues or a duration of time or a severity of disease, to be able to offer this and to know they're going to have a positive response to it, I think is key. So knowing that essentially all patients who come may be eligible to utilize this therapy. Certainly this idea of GSM, the idea of women experiencing genitourinary syndrome of menopause, patients who have a lot of what are called LUTs or lower urinary tract symptoms, ties completely into that arena and into that, service line that you have, in the fact that these are patients who may be suffering with other things, but a component is definitely overactive bladder. And that this is a therapy for those people that are active, that are otherwise, seeking care for those other symptoms, but have a significant burden with this, could be helped. And this may tie in and dovetail well with therapies that are being offered for that problem.